Well, good afternoon. My name is Annette Gardner, and I'm a faculty member in SBS and IHPS here at UCSF. I'm also the director of the Institute for Health Policy Studies Evaluation Community Practice, which focuses on sharing and professional development. Thank you for joining us for our third Evaluation Brown Bag Lunch this year. They are an opportunity to hear about evaluation design and findings, as well as get into the weeds about the ins and outs and how these designs were developed and conducted. We are also scheduling a skill-building lunch this fall that will focus on data visualization. So please sign up on our list today so that we can include you in our future emailing. Even if you are not a self-identified evaluator, we welcome you. So I'm going to introduce our speaker. And today we are delighted to hear from Jason Flatt, an assistant professor at the Institute for Health and Aging, the University of California, San Francisco. His overall research program aims to address disparities in dementia risk factors, treatment, and care. As part of the UCSF Health Workforce Research Center in long-term care, he is currently leading an evaluation of the services and staffing models for adult day health centers that provide care to persons with Alzheimer's disease and related dementias. He also recently completed an evaluation of California's Dementia Care Specialists project, which aimed to increase the dementia capability of health plans care managers. He is also co-leading the evaluation of two 3-year Alzheimer's disease initiatives, specialized support and services grants with San Francisco's Department of Aging and Adult Services in San Diego County. He has experience with both qualitative and quantitative research methods, including online surveys, cognitive assessments, focus groups, in-depth interviews, and the analysis of longitudinal data. Today, Jason will be speaking on a new workforce in California, exploring the role, preparation, and practice of dementia care specialists. We are recording the session and hope to load it to the Institute for Health Policy Studies website in a couple of weeks. Jason.
Great. Thanks so much, Annette, for having me today. So I wanted to tell you a little bit about this project with Dementia Care Specialists and share, this was a project with the UCSF Health Workforce Research Center on long-term care, and funded through the Human Resources and Services Administration, so HRSA. So really to give you a little background about this, we know that dementia, especially the increasing prevalence of it here in the U.S., is a major problem. And it's going to become increasingly so over the next, 15 years or so. Even by 2050, we're expecting to see a huge rise in the number of people with dementia. And for this presentation, I'm saying sort of dementia, but this represents Alzheimer's disease and related dementias. So we will see by 2050 about 16 million people will have ADRD. And one of the challenges we're posed with is how are we going to care for this growing population? So there has been work showing that care coordination can be important for delaying institutionalization, improving quality of life, and this is for people with dementia as well as their caregivers who are going to be taking on a lot of the burden of care. And Dementia Care Specialists, which I'm talking about today, is a potential solution here in California for health plans to better support their members. So these are members who were dually eligible for both Medicaid and Medicare, so a pilot program looking at this group, and really to focus on keeping them in their homes as well as supporting caregivers and their families. So here in California, we're also seeing a huge rise in the number of people with ADRD. So we know currently it's over 680,000 adults that are aged 55 and older that have dementia. And this number is going to increase dramatically. We will likely see over 1 million people by the year 2030. And one of the huge challenges is the caregiving piece. So we see here in California that Californians are providing a lot of the care for people with dementia. And just in California alone, this represents about 11% of the U.S. caregivers. Also see here just sort of, this Figure 1 depicts sort of this gradual, what we're seeing is this huge percent increase in the number of people with Alzheimer's and related dementias. And you can see here it's almost 100% increase is what they're expecting by 2030. And this is going to have huge implications for healthcare. And really, we already know, I had talked about this group that uses Medicaid and Medicare, these dually eligible individuals. So that program here in California is called the MediConnect program. And we're seeing for people with dementia, they are in the top 5 for healthcare costs. So this is a very important issue for California to really address. So the objectives of this evaluation were really to examine the role of dementia care specialists in California. It's a new position that was proposed for health plans, and really what drove this was through the Center for Medicaid and Medicare Services, the requirements of all health plans who were in the MediConnect program needed to have a dementia care specialist. So our other focus was really to learn at what were their qualifications, what types of training did they receive, what were their actual care coordination practices that they were using with people with dementia, and then to think about the long-term implications. What does the demand look like? How are they recruiting people as well as retaining them? So that was some of the focus of what we did. So what is a dementia care specialist? So this is a person, it's a healthcare professional, and typically they're trained in dementia care coordination, and they have a very experienced and detailed understanding of what the needs are for a person with dementia, as well as the needs for their caregivers. Now, qualifications, these are, I'll be talking more about what we found, but typically we're going to see it's either a nurse or a social worker. They propose that they have at least 3 years of experience, specifically hoping that it would be in case management with people who were older, as well as understanding some of these key pieces around assessment, treatment, and the care planning process. So the MediConnect Requirement. Basically, as I had said, this is a 3-way contract. It was between CMS, the California Department of Health Services, and participating health plans. So the guidelines specifically put out there that they need to have staff who can provide dementia care management. They need to understand dementia and know the symptoms and how the disease progresses. They must be knowledgeable and able to manage behaviors and communication problems, as well as understand how to manage caregiver stress. And then another component of this was really focused on utilizing community resources for caregivers as well as the members. So with the Alzheimer's Association of Greater LA, as well as the Alzheimer's Association of Northern California and Northern Nevada, they proposed a solution to addressing, to meet these CMS requirements for the MediConnect program. So they came up with a dementia care specialist training program. And really it aimed on improving their capacity to provide dementia care coordination. And they targeted care managers. It had 3 different modes for this training. So in Tier 1, it was an 8-hour training that really focused on the basics of dementia, the disease progression, so an educational sessions that included activities, problem solving, as well as role playing, sort of how to handle situations, perhaps dementia behavioral problems, or dealing with caregiver stress. They learned about cognitive screenings and assessments, as well as referral resources. So that was the basic Tier 1 training. Now, in order to move to sort of the dementia care specialist, you had to complete Tier 1. Then for individuals that completed Tier 1, they were nominated by their health plan to participate in a 2-day training, which is the Tier 2. And this was 12 hours, so much more intensive and really had a lot more hands-on practice, really a detailed understanding of how to do cognitive screening, as well as they used a method called IDEA, which it's an area of solving and dealing with behavioral challenges when someone has dementia. So some things may be wandering, inappropriate behaviors, how to redirect, but also how to be in the moment and understand some of these challenges with dementia. So they spent, basically 2 days, 6 hours each day, doing really intensive problem solving, working through different case scenarios, as well as even role-playing how they would work with a caregiver, how they would use the different assessments, and how to refer to different organizations that could provide support. And that may be the Alzheimer's Association, it may be an adult daycare center, it could be respite for the caregiver, different aspects of that, and care planning, so working with primary care or a geriatrician to work on the care plan as well. So after the Dementia Care Specialists completed this 12-hour training, they were then asked to participate in monthly 1-hour huddle calls. And these huddle calls, it went for 6 months, but what it involved is all of the Dementia Care Specialists from the health plans would attend this call, and they would have 20 minutes of sort of an in-service where they're refreshing either a concept or learning something additional about dementia care or care coordination. And then the rest of the time was really focused on them bringing real-world problems, so some of their difficult cases they may have been handling, or scenarios, and really giving each other advice and walking through how they would solve some of those challenges. And this training, sort of these different tiers, were really based on, an evidence-based model called ACCESS, which represented basically, it's looking at, Alzheimer's disease coordination and developed for San Diego. And this was a randomized control trial that utilized a lot of these methods, and they did see, compared to the control group, by using some of these models of dementia care coordination training and, caregiver support, that they saw improvements in the quality of life of people with dementia. They saw reduced levels of stress in the caregivers compared to the control. So really this is based on an evidence-based program that has already been tested. So ACCESS, what is ACCESS composed of? A little more. It has 4 components. So it had a steering committee that really thought about what does the appropriate dementia care coordination and goals look like. So they developed a very detailed care coordination plan. They targeted education for care managers. They also provided education, and it had a web-based component where they had a communication and decision support system. And this program was really, it built off of the chronic care model. So they were trying to inform, this model, which has now been adapted for the Dementia Care Specialist program to kind of incorporate these different levels of the health system. So the methods for this evaluation involved in-depth interviews with 17 key informants. They were from the health plans, 8 health plans throughout California, both northern and southern California, and some of the trainers, and also one of the academic researchers and a vice president from the Alzheimer's organization. So we did a semi-structured interview with them, which I'll tell you a little more about what that entailed. But basically, it was a phone interview. I audio taped and then had it transcribed. And really, another piece of this was reviewing some of the documents, so the training materials, the CMS contract, and then after we transcribed, these interviews, we used a thematic analysis to really look at the overall key themes that were represented from, these interviews. So that here's what the interview guide focused on. So really, as I was talking about, it was really tailored to thinking about the role, practice of dementia lists, what does their care coordination look like, so their caseload, what sort of training they previously had, as well as any needs, and then thinking about how they were evaluating what they were doing and some of the future demand for this position. So some overviews of the project. Really, so I interviewed 9 care managers, 2 supervisors, 2 directors, 2 vice presidents, a chief medical officer, and I had said already an academic researcher. I really wanted to focus on also getting the perception of dementia care specialists, so I interviewed 6 dementia care specialists and 2 of the trainers. And it was all 8 health plans that had participated in this project with the Alzheimer's Association. So these were the key ones that received the training and also were participating in the MediConnect program. And these are a list of the 8 health plans here. And on average, when we were looking at how many dementia care specialists do health plans have, on average it was around 3 to 4, but this varied. Some may have had up to maybe 10 versus some may have only had 1 or 2. And over the 3-year period of this project, about 50 to 60 dementia care specialists were trained. And one of the things I found was there was quite a bit of variability in how much work these, care managers, I'll refer to them sometimes, or dementia care specialists, how many members had dementia. And it varied quite a bit. Some were maybe seeing maybe 2 to 3 members in their caseload versus others may have said, more than half of their caseload was people with dementia. And really it depended on sort of their practice setting of how that was shaped. So looking at qualifications, basically we saw that they were either bachelor or master prepared. So they were nurses or social workers. And really how they were decided upon of sort of participating as a dementia care specialist, it depended. It could be based on their seniority, how long they had been at the health plan. It may have been their background, so they actually had experience working with geriatric populations in the past. Or some health plans based it on just an interest. Are you interested in participating in this training? So that was sort of, a huge piece of it. Like I had said, with the seniority, many of them were supervisors, and we actually did find that some were promoted right after completing the dementia care specialist component. But the major reason for why they were selected is they had to participate in Tier 1 training. So some findings on the role and practice. So dementia care specialists, this was a piece that was very important, especially at the health plans that did a lot more of the telephonic case management, was that they had dementia care specialists serve on interdisciplinary care teams. So this was a big role for them. So what they would do on these teams is they would recommend, sort of based on an individual that has dementia, they would add components to the care plan. They may recommend that the person go for follow-up based on the cognitive screening results. So this interdisciplinary care team may be a nurse. It may be a social worker, some other supervisors. There may be a physician on this, but not always. So they were sort of making recommendations based on what they learned from the training, what would be the appropriate care plan for this individual with dementia, as well as potential services for the caregivers or family. So some of the dementia care specialists also trained existing staff. So this may be an in-service that they offered. A part of this program, and I didn't say this at the beginning, but Tier 2 had a train-the-trainer component as part of it. And not necessarily was this well-known, but some of the dementia care specialists did go back to their organization and provide a training, sort of a teach back to other care managers of what they had learned and what are the best practices in dementia care coordination. Others were used less formally, so they may just be known as a resource for other care managers. So if a care manager at their health plan, had a difficult case for a person with dementia or had questions about maybe the care plan, they could utilize this trained dementia care specialist to give guidance on what would be the next steps. But one of the challenges for health plans was really that there was no formal recognition that they were a dementia care specialist. So it was really through word of mouth. The health plans weren't necessarily calling this person a dementia care specialist or putting anywhere internally that people would know to go to this individual for their expertise. So that was a huge limitation in sort of how they could be utilized. And as I said, the practice setting really varied, and I found that this drove a lot of sort of how useful the dementia care specialist might be to the organization. So some were doing telephonic, so all of the care management happened on the phone. So that would limit, they were not ever seeing the member or the caregiver. A lot of times they were just interacting with the caregiver and sort of making recommendations. But there were some dementia care specialists, and it was more often social workers that they would do in-person or even in-home visits, and that would be where some of the care coordination would happen. So they could do more direct assessments. They'd be able to assess the caregiver's needs quite a bit more. Some were also at either social service or long-term care coordination agencies as well. So they may be actually going into the assisted living facility to meet with a member, or they may be actually going to one of the adult day health centers, and they would do some of the coordination there. So it really varied, and it was really based on sort of what the practice setting for the health plans were at. And also the involvement of the caregiver, I found, was really driven by this. So depending on the scope of practice, they were maybe interacting more or less with the caregiver. And it really had to do with also how long their sort of duration of the care coordination happened. So we did see that some were, just around 3 months, sort of stabilizing a member, making sure they had everything that they needed and set up, versus others saw a more long-term relationship with the member where they were sort of developing a care plan for them over time and keeping the client as part of their caseload for much longer. So here's just some quotes that give examples of what these caseloads would look like. So you can see here that it ranged from they may have 20 or 30 patients they're working with, and they gave examples of doing discharge planning in the hospitals, but their overall caseload might look more like 100 people total, right? And then other groups that had much higher caseloads of people with dementia, they had much less. So this would be one that was working maybe in long-term care settings or in the community with social service agencies. They saw about 15 to 20 for a normal caseload, and said more than half had dementia. So it really varied. You can see here just of the quotes from some of the dementia care specialists, what they said. And as I had said with the practice piece, just to support this, you can see here that, really how they were utilized was different. So some were just sort of treated as a consultant, and if it was asked, if they needed the support of the dementia care specialist, others would have to seek them out, versus those others had a more formal role where they served on these interdisciplinary care teams and could make more recommendations and sort of be a part of the overall care plan. So it did vary quite a bit by the setting. There were also, with some of the care coordination, there were inconsistencies in sort of what they were doing. So a lot of this, I felt, had to do with the system infrastructure. And so what I mean by this is, did they have a system in place really that focused on dementia care? So did they have a tracking system? Did they have some of the assessments built into their infrastructure? So when they were doing it telephonically, were they able to kind of walk through a flow or a workflow, if you think about it, of the necessary pieces that they would do for care coordination. So that varied quite a bit. Some were just utilizing parts of it. Others were not necessarily using the same cognitive screen that was recommended by the training program. So that was the 88 that they were recommending, an 8-item cognitive screen. So some used that, others used the health risk assessment that members filled out. But a concern was they're not necessarily filling those out annually. It's often done, when they first enroll. So that infrastructure really affected, how well the dementia care specialist could be utilized and what their care coordination looked like. And then, there was also a piece around who was responsible for the care coordination. So sometimes the health plans took a lot of ownership versus other times they would put it, more towards, a hospital or the primary care physician, feeling like this is not our responsibility to meet, all of the care needs of this individual. So what we do is just refer them back to their primary care, and not really doing as much of a detailed and organized care coordination plan for them. So that was a challenge. They were more just managing doctor's appointments and maybe checking in to make sure that certain things happened and not necessarily taking more of kind of the lead on the care plan. So then what I did find, though, was caregiver supportive services were quite common. So almost all of the health plans had some level of caregiver interaction and referral. It did vary in the scope. Some of the health dementia care specialists, as part of their health plans, would actually do screenings looking at stress of caregivers, even if they were not a member of their health plan. They still would provide those services because they knew how important, the caregiver's health is to maintaining, sort of this care plan and helping their member. So they would provide those services versus others, more of just did a basic referral because they were often, interacting with the caregiver when they were working through the care coordination concerns for the member with dementia. Some of the top referral areas that we were finding was most of them were all using an Alzheimer's organization. So that was their number one referral source that they would use. Many of them were using caregiver support options. So this could be support groups, respite. So those tended to be some of the common ones. Some of them actually helped with either placement or referring to assisted living when it was found that, care could not be provided in the home any longer. So they may look into that. And then, as I had said before, a huge piece of it was focused on medical care or referring to specialists. So an appointment for another screening, medication, they had some of those pieces in there. You need to, re-see your doctor again about maybe, one of the dementia medications. So it really, these were the top areas. There were also some facilitators and challenges to the training as well as the overall dementia care coordination by a specialist. So what we found for some of the facilitators was really that policy was a huge driver. So this was what really got the buy-in from health plans was because of the CMS contract that they had to have a dementia care specialist. So we also found, though, that most of the organizations, buy-in still was a huge piece, that their senior leadership really supported having these trainings. And an example of this is some of the organizations actually paid for the Alzheimer's Association to come in and provide the training to their care managers. So they had really bought into the importance of this for their members. There was also a concern around cost. So obviously these plans are very concerned about minimizing, the costs of care. And so that was one of the drivers they talked about. And one of the challenges, though, is we found that, with the evaluation piece and sort of this infrastructure issue, they weren't necessarily capturing what might be the cost savings. Reimbursement for the care coordination really just came through the standard sort of what they were getting from CMS for reimbursement for care. So there wasn't a separate billing that they could bill for this enhanced care coordination. And so that is something I think in the future could help to further kind of promote this program. And the trainings, so the dementia care specialists that I interviewed as well as the care managers talked really highly of the training. They felt they were very interactive. There were limited challenges in completing. The model was really adapted to the dementia care specialists, thinking about how to make it most feasible for them to complete. So, for instance, initially they were thinking of 2 separate days of full training, but they had condensed that Tier 2 into 12 hours to kind of give more flexibility. And there was also sort of an option for people to attend at other sites. So they really tried to make sure if there was one in LA, that, all of the health plans that are within that region could come to a training that was at a different site. Some of the challenges, though, of the training was really participation after completion of this Tier 2 training. So the huddle calls, they were 1 hour per month, but they did find that the turnout was really low at times. It was really hard to get buy-in after the training. And this had to do a lot with, the health plans not providing special, extra time for their dementia care specialists to actually attend these huddle calls for 1 hour. Some other challenges I had talked about, the system infrastructure. So many of the dementia care specialists and some of the managers talked about they're starting to integrate the dementia care coordination into their systems, but they found it to be slow and very challenging. So it has to do a lot with just how time-intensive and how many people are involved in the development of their systems for care. And so many were trying to build in the cognitive screen. They were trying to build in a piece for caregivers, as well as ways to measure sort of the impact of their dementia care coordination, but it was just very slow. And, building on that with the metrics, really having appropriate metrics. This was not a part of the dementia training for the dementia care specialists, so many of them didn't know what metrics they should be collecting, and few had, something in place to really assess this. So, for instance, when I asked about any potential cost savings of doing, many of these dementia care specialists and health plans had been, doing this program for over a year. And so when I asked about, how are you measuring sort of the impact of what you're doing, cost savings or potential benefits to the members, many of them just said, well, the main thing we do is we audit calls or we audit cases, just to make sure that someone's doing something appropriately, but there was nothing in place to really see, address the impact of the program. And then a huge challenge, and I think that it's part of, health plans, is that staff turnover is quite high. And this was also the case for dementia care specialists. I would probably say that more than half of the people that were trained as a dementia care specialist either left their organization or they were promoted, and so sort of their role at their organization was very different. So they were no longer consulting or serving on these interdisciplinary care teams. One of the high points, though, is that many of sort of these health plans sort of compete with each other, and many of the staff are going back and forth to the different health plans. So a great piece of this is that, some of the other health plans were gaining a dementia care specialist. So that is a piece. And then some of the promotion is still encouraging. And one organization was actually rolling out the dementia care specialist training program to their entire organization. beyond their sector that was focused on MediConnect. So implications of this, are really just thinking about, the demand for this is quite high, and we're going to see, a greater need for the workforce to really be prepared to provide dementia care coordination. This model of training, care coordinators to be specialized in dementia could definitely be something that could be looked at nationally. So California really is a leader in kind of showing what could be done. And this train-the-trainer piece is especially important. So we're already starting to see that it's spreading, right? So other health plans are starting to participate. There's been a greater demand for training. They've started to offer it online, as well as I list here the states that have already started to participate in the training. So we have, here already it's like 5 states and Washington, D.C. So we will see that this expands. So that's the key pieces of this project. I want to acknowledge my collaborators, Susan Chapman and Brooke Hollister, as well as the Alzheimer's of Greater Los Angeles, those from the health plan, and then here is the agency that supported the project. So I'd like to open it up to questions.
Great. Thank you so much.
Yeah.
I just want to weigh in with a couple of comments.
Sure.
Just to sort of in the name of evaluation skill building.
Yeah.
So one thing is to let people know that whether this is a formative or summative evaluation, and that whether you're doing process evaluation, and that indeed this does sound a lot like formative or process. You did inquire about how are they looking at effectiveness, so we kind of know that they're not. So just to help situate people in kind of where in evaluation speak are you?
Yeah.
And I also thought, I just want to comment on, many times there's a tension between qualitative and quantitative data collection, and so we reconcile that by calling it mixed method. But I just want to say you managed to extract quite a few findings and a lot of detail through your qualitative interviews, which I sometimes think goes unrecognized. And the only suggestion I have for the future, if you're talking more to an evaluation audience, is to maybe talk about what is thematic analysis, so we can understand your categories and whether you used, what did you do around inter-rater reliability. So, but again, that gets into the weeds where your audience is perhaps a little more up to speed and wants to delve into qualitative methods. So, and then just my last comment is that I've been evaluating interprofessional collaborative team programs, one in particular at the VA, and it's really interesting to hear some of the same themes about, yes, our training module is standardized and it's been tested, but the adoption is a lot of variability. And it kind of makes you step back and ask, well, how do we get to coordinated care when the healthcare delivery system, plural, offers so much diversity in how these programs will be adopted and their uptake and dissemination. So even though this isn't my area of expertise, there's a lot here that's really relevant to the type of programs I evaluate. So kudos for bringing out a lot of the detail and helping me think through my area.
Yeah, great.
So others, yes, please.
Yeah. Thank you, Jen. This was fantastic. And since we're talking about evaluation, it's an area where I'm not that familiar with. My first reaction was I would really question the fact that this person's a specialist based on a training of, remember the first tire was 8 hours, right? The second tire is 12 hours, and then we got to 6 hours within 6 months. And it just makes me think about my own training in dementia care. As a part of the care, I took a lot of training on dementia. And just to be able to administer the MOCA to the best of my abilities with Julina, our common mentor, evaluating me, I think it took me a good maybe a full week of work with so many training, different people involved, and so I really, for me, these persons are not specialists, and that at the gut level, and the fact that the word specialist is based on this training in San Diego.
Yeah.
And so I would be really curious to see whether that's really the case, and I'm comparing the training that the home care aid in Denmark are receiving. I don't know exactly the details, but they are taking, I would say, at least weeks or months of training to become the dementia care specialist.
Okay.
So yeah, I wanted to, and also how many of these persons, they see the persons over the phone. So there is a disconnect. They want to keep the person at home, but they rarely see them at home.
Yeah.
And also how many of these dementia care specialists are helping people who are living alone with dementia, and so couldn't have often caregivers, according to my experience. So these are, maybe there are too many questions to answer within several other persons here. But
yeah.
Just food for thought.
Yeah, so I think the first piece, I think what's different between sort of, why they're calling them a dementia care specialist is really the focus on dementia. Many of them have been doing care coordination for a long time, so they're quite specialized in that piece. And I think that what they're doing here is just adding, the focus in dementia. So I agree that it may not necessarily fit other description of what a dementia care specialist might be, or that advanced level of training. I know some of the concerns are this isn't, they're not certified in doing this. It's not sort of like there's an exam or any piece of that. The thought is more that this adds to what they're already doing and helps them to have some existing, some additional knowledge and maybe some additional skills to enhance the care coordination that they're doing. The Alzheimer's Association really came up with the name Dementia Care Specialist. I don't think there's necessarily, does that really, it's more a dementia care coordinator or a dementia care manager, because they're managing the care for a person with dementia, and so this is, I think the program was just aimed to enhance that care. For your piece on the living alone, that wasn't something that came up, and I, sort of my initial thought is that they're probably not, the only living alone populations that are probably addressed in this would be people that are in institutional settings that they provide care to, or at some of these agencies. So they've been connected already to adult daycare. Because many of the, these dementia care specialists, if they're doing it telephonically, they're interacting with the caregiver, whether that's a paid, so it may be a paid caregiver if someone that lives alone could set that up, which, I know there's a lot of challenges for people living alone in sort of doing that. So mostly it's going to be people that have a family member or, but maybe they live alone and the family member is doing some of the coordination via the telephone with the, out of state or within the, I don't know enough about that for this project, but yeah, good points though.
Yeah. So maybe my first question would be more of an evaluation question. Maybe this is fascinating.
Yeah.
I've learned a lot, and some of the things that you brought up, particularly in relation to the later part, the second part, when you were talking about the facilitators and barriers in terms of implementing this program, makes me wonder about whether we can ever evaluate just the effectiveness of that particular program without also evaluating the larger system and the context within which this program is being implemented. Because when I was listening to the description of the barriers and so on, it almost seems like the least integrated, least coordinated programs are the ones who really need these specialists, whatever we call them. The ones that are the best coordinated ones probably don't need them as much. So their quote-unquote effectiveness, if they were really measuring the may actually be less for the DCS, right? Even though that may be because the programs were much better in the first place. So I guess maybe as the evaluation question I have is, how do we think about that? One way to think about this is that what Jason has presented is a very good descriptive, informative, where we're looking at the process and providing input on how this program can be strengthened. But this can also be the stepping stone to the summative evaluation, in which by developing the codes and the themes and the topics and piloting questions that can be then rolled into a survey, and then you can start thinking about experimental or quasi-experimental design. So you can see it as a step in the direction of, and then you can start figuring out your independent variables. And when the other way to look at the context piece is to always have as a sort of a monitoring and document analysis on what the context is. And so you can start coding in the various types of plans and organizations and finding a way to organize that material. And then again, when you do a real experimental design, whatever, you can start putting those in as variables. And so that's, like I said, one way to frame it. The program has been underway. It's been like a year to 3 years?
It was a 3-year, grant that basically, so I was adding an additional evaluation onto their grant.
So this is really interesting because this program is mature enough that if they had thought about this when they had designed the program, they should have said, well, how are we going to evaluate this earlier, and have sort of answered those questions a lot earlier by saying, well, where can we get a control group? Is there another state? Is there another aspect of the healthcare delivery system in a comparable population? But they didn't. They brought Jason in, and he's able to inform the program in terms of its implementation, and now set them up for, like you said, the cost savings, because that's usually a huge piece. Now, the last dimension is, what do people really need to learn about a program? And maybe they already thought about whether to look at effectiveness, but said, no, our resources are more about meeting this unmet, this pent-up demand. And we know this program works because we have evidence from San Diego. So we've decided we just want to know more about the inner workings of this program in different sites, and they have taken off the table by choice this desire to try a more research, put on a research spin or focus. So you kind of have to come back to, as an evaluator, to knowing what your stakeholders want to learn, and your role is to put out the options for them, give them a sense of the limitations, like can you get a control group? Is your sample size going to be any larger than 5? And if not, what does that mean? So, and this is the design piece. And so, and the more you do evaluation, the more you get this really under your belt, and you can learn it in like graduate level certificate courses and the like. CTSI here at UCSF has evaluation courses that would help with all this front end design work.
The implementation science.
Yeah,
right?
Anything?
Yeah, I think that's and you're exactly right about, I came in as sort of an additional evaluator, thinking of like, how would I evaluate the impact of, this Dementia Care Specialist programs that they've developed. They did evaluate like the training piece, but really it was just like satisfaction, knowledge, some of the typical things you see with a training evaluation, but not the richness of, I'm the one who found out that, for instance, the health plans don't have an infrastructure to look at cost savings or the impact of the program right now. So I identified some of those gaps. I think that some of this project being rolled out to other states potentially could lead to a future way of evaluating it. My concern, though, as I learn a little bit about it, is like program fidelity. So are they actually taking the program and implementing it the way that it was designed? Probably not. Some are customizing some of this to their organization because this program is no longer overseeing how they use it. So that is a limitation for the future. But I think that it still holds some promise as a model for health plans. We're going to see, sort of this increase in demand for, dementia care coordination. And that's what it offers. But it definitely has some. And I didn't have a slide on my limitations, but I think I definitely could talk about, the fact that, I did not get everyone with the high turnover, so it was about 28 people. I got names of 28 people total. I got 17 of them, and no one refused to talk to me. It was pretty much their email or phone number that I had for them was no longer working. So it just shows you the turnover piece really had a huge limitation, and perhaps those people that left did not have the kind of success, and they could have shared a different perspective.
I forgot to ask, what did you analyze the data in vivo or or Atlas TI?
In vivo.
Okay.
I use in vivo, yeah.
Because that's a whole topic of in vivo, deduce, Atlas TI, or I use Excel.
Yeah.
Oddly enough.
Or some people use even Word, it doesn't give you as much of but you just pull the codes, or So that's I use in vivo.
I actually had one of my questions was about the turnovers and how you were able to actually assess that and what that meant. But I see that's a limitation.
No, I got turnover even. I asked the plans about it. So I would ask them how many total people were trained from your organization, and then how many of them are still here. And that's how I was hearing even, about the
idea of like reasons for why people were leaving.
Some were saying, so the difference in those that had low turnover was like the institutional kind of, like the supportiveness and collectiveness of the institution. So they would be like, we're really team-oriented, we really support people, we want them to stay. So they had more of sort of a more collective kind of organization that was supporting their employees versus the other ones, I think, fit this more standard. I used to work at a health plan, right? So a more sort of competitive model, less of this, team-oriented culture. So I think culture was a piece, but that was just from a few people that said it. I don't know if that's totally it's also to get promoted at some of these organizations is very difficult, so you have to keep leaving or jumping to different organizations to move up.
Exactly. I'm thinking about the labor market dynamics of this, right? Because we have such a small still in the process of building a real workforce in this area. So organizations teaching one another's specialists. And then on the other side, I can't remember if I saw it on your slide where you listed your methods and interviews, but given that there's a nascent demand and emerging demand on this side, were you able to actually talk to any caregivers that there is some value add in this position?
Yeah, so that wasn't
kind of the staff pressuring supplier use demand.
Yeah, it was just focused on the organizations and some of the trainers. There were no interactions with caregivers, or that would have required a totally different IRB, and getting the health plans to give me, the contact information for a caregiver would have been especially challenging. I doubt they would be willing to do that.
This is always such an interesting issue about how you get at the patient, the provider, family, and the HIPAA requirements, and I have to say that the set of tools that around the patient experience of care, too, the CAP tools that are coming out because of the movement around patients that are in medical homes are finally seeing some reasonable instruments and questions that have been piloted so that you can put those into your interview template.
Yeah, Jenny on the question about caregivers, but ultimately we also like to know from the patients themselves and the clinicians But you did a great job. I had a project with the same funding source with telephone interviews, and I'm just very impressed with how much information you were able to get out quickly. But this is a huge issue, and this is just, a baby step. Well-meaning and a start, but it's really an overwhelming problem, and we need to be much more serious about it.
Yeah.
Just because we are all creeping our way to this age group ourselves. But I just want to thank everybody. We went a little bit over, but that's good again. And thank you, Jason.
Yeah, thanks for having me. Thanks. Bye, everybody. We're coming.